Hello again, this is Narelle Ellendon from the New York State Office of Drug User Health. I'm excited to moderate this session. With new formulations of buprenorphine, such as extended release buprenorphine, it opens the doors to new possibilities for people in different settings and communities with co-occurring issues, different stages of their drug use and lives. So I'm very pleased to introduce our two presenters for this session to explore this topic. First of all, we have Dr. Sarah Spencer, who is board certified in family and addiction medicine, has been providing treatment for opioid use disorder in rural Alaska for over a decade. She currently works with the Nilchik, I hope I'm saying that right, traditional council at the community clinic that provides family medicine and addiction treatment services at their tribal clinic, and that also includes telemedicine to remote native villages. She works with Project Hope to provide opioid overdose response training and naloxone distribution, and is a founding member and volunteer medical director of Alaska's first rural syringe access program in Homer. She is co-author of the state's medication-assisted treatment guide, the head addiction medicine consultant for Alaska Native Tribal Health Behavioral Health Department, and is in the state's senior physician consultant for the SAMHSA-funded Opioid Response Network nonprofit consulting program. And then following Dr. Spencer, we'll have Dr. Nick Batson. He's a physician specializing in behavioral health at Crystal Run Healthcare in upstate New York, a position he's held for nearly 10 years. He is a board certified in adult and adolescent psychiatry. He leads Crystal Run Psychiatry Division that serves children, adolescents, and adult patients that use drugs, as well as a variety of conditions such as depression, anxiety, ADHD, as well as bipolar, autism spectrum, developmental, disruptive behavioral, psychotic disorders, all the disorders. Dr. Nick Batson earned his BA from the University of Louisville in Kentucky, and earned his medical degree from American University of the Caribbean School of Medicine in St. Martin. He completed his residency in psychiatry at Wake Forest University Baptist Medical Center in North Carolina, and completed his fellowship in child adolescent psychiatry at the University of Louisville. So thank you very much. We'll kick off with Dr. Spencer.
Actually, Narelle, I think we'll have Dr. Batson goes first, if that's okay. Sarah, I think that's how we had wanted to do that. Yep.
Very good.
That's fine. Sure. Let me, hi, everybody. Thanks for attending today. And some of y'all may have heard this in the past, but there's been some updates since then. So can everybody see that? We have that in a row. So, you know, a little play on, I think this is Shakespeare, to inject or not to inject. That's the question, right? And so as we're figuring out what to do with these different formulations, let's see here. So we'll talk a little bit about long-acting buprenorphine, patient selection, and then just kind of some of the clinical, operational, logistical, like how do I do this, right? I mean, we can all read about it and hear about it, but the things you want to know is how do you actually do this? So what's Sublocade? It's just like, you know, buprenorphine. It's indicated for moderate to severe opioid use disorders, but patients have to have tried or been on the oral form of buprenorphine for a minimum of 7 days. Some of this is just a tolerance, just to make sure that they're doing okay before you give a medication that could last up to a month in their body. If anybody has seen the movie The Matrix, that's what makes this formulation unique. It's the matrix that it has. So it's a subcutaneous injection. We'll talk a little bit more about why that's important kind of down the road, but it has a special delivery system that the body takes in, this polymer. You know, you describe it to the patients, you know, hey, you're going to have this matrix of a polymer that's in your body, and your body's going to break it down over time. And that's where the extended release portion of the medication happens. You know, it is just a buprenorphine. It's not the combined product like the Suboxone is. So just a little bit of kind of how it works and what happens. So you have the subcutaneous injection. It goes in the abdominal region that's there. And the patients will have a little bit of bump. It's almost like you got like a really bad mosquito bite or something like that. I have a picture in a minute we can take a look at. But you have to rotate it. In our office that we do it, I do it mostly in an outpatient setting. We have the nurses do it, but a physician, nurse practitioner, PA, anybody could give that injection. Just a little bit kind of fancy science stuff here, the pharmacokinetics with this. The plasma concentrations for just Subutex, which is just the buprenorphine, talk about nanograms per liter, per deciliter. So if you can kind of see here, we have the Sublocade shot 1, which is 300 milligrams, and then the 100 milligram. Those nanograms per milliliter, per deciliter that's there, it's equivalent, if not even a little bit higher, compared to some of the oral formulations, which may have some benefit for some patients. And then just some things, again, this works on the mu opioid receptors in the brain. It has about a 75 to 92% occupancy rate, and it stays there for about 28 days. For some people, a little bit longer, a little bit less. But 28 seems to be about the average. There is a little bit of variability in the first couple months, which we'll talk about in a minute, of why that may be important for your prescribing piece that's there. If anybody knows about like pharmacodynamic stuff, I mean, typically you're looking around right about 80% of receptors, at least in the psychiatry world, for most of our medicines to actually be effective. So it's kind of cool with that. I put this kind of graph up here because it's important to look at plasma concentration. So this slide looks like it's from like the 1980s, and sometimes you have to borrow these from some of the academic literature that's there. But it has the sublingual, which is the darker, which is the lighter gray line, and then the darker line is the injectable form. And so if you can see on you have the X and the Y axis on the time frame there, right at about 4 hours, this crosses. So what this tells you is that 4 hours after taking the subcutaneous injection, your plasma concentrations are equal to what the oral form is. So this matters when you're, particularly the first couple of times in the initial dose of the Sublocade, you explain to patients, hey, I want you to take your oral medicine in the morning, but then you don't have to take it anymore after that, or not necessarily in the morning, whenever their next dose is due. But one of the ways we like to do is have them take it in the morning. Say, take your medicine in the morning, we're going to give you an injection, and within a couple hours, your blood concentrations are going to look just like you have the oral form in your body, and it's going to stay that way for a long time, for many, many days and weeks. And so I think this is an important kind of graph, and it also helps explain to patients who are worried about going in withdrawal, hey, we're going to get you there with the medication, we're just giving it to you in a different way. So the dosing strategy, the way this works is the first month, you give a 300 milligram injection. For the second month, you give a 300 milligram injection. And then for, third, fourth, fifth, all subsequent months, you can go down to 100 milligram dose. And it's helpful, again, for patients that are on any range between 8 and 24 milligrams. So it's really kind of for everybody. I think one thing clinically that at least, we see sometimes in some of the other folks that are using the Sublocade is about half of patients will stay on the 300 milligram dose. You may go down to 100. They don't go into withdrawal, but patients will say, hey, it feels a little different. Like I kind of feel a little off. Not that they're in withdrawal. Maybe their sleep's a little off. Maybe there's like, I kind of got that internal like restlessy feeling. Nobody's coming back saying, oh my gosh, I've got a COWS score of 20 and I've got stomach aches and I'm throwing up. And so none of that kind of stuff. Again, this is a very long acting medication. And then there's no end result with this, right? So if you need to take it for 6 months, 12 months, 24 months, however long you need to take it, there is no end date, right? So however long you need it for your recovery plan, that's what we're going to use it for. But we do recommend 6 months because it takes about 6 months for it to actually reach a steady state in the body. You can stop it after 6 months. And there's some studies that show that it is still in your body at a detectable level at up to 10 to 12 months after your last injection. So it's got this, again, very, very slow kind of metabolism taper pattern with it. Just, cost. I mean, we do have to be mindful of healthcare, and our healthcare costs are going up. The average, this cost is maybe from about 1.5 years, 2 years ago. I think it might have gone down just a little bit. But the average cost of an injection is about $1,700. This, in my thought, and some of the things we see, this is actually probably a cost saver for the healthcare system, right? We're keeping patients from going to the emergency room because they're in withdrawal. They have their medicine, no problems there. We're actually shifting care more towards an outpatient setting, not in the hospital, not in intensive outpatient programs. We can get them to a, kind of a better place of care, a less intense place of care, and it will probably actually save cost. The other thing is corrections, and it's great. I saw in the last presentation, we're talking about, what corrections and what they're offering as far as MAT. but have had some discussions kind of regionally with some of our correctional facilities. And, one of their concerns is about giving the oral forms of buprenorphine is that they have to sit and watch the inmate. They have to have a nurse there, a medical staff. They have to have one, if not two, correctional officers sit, wait for it to dissolve, transport them to and from facilities where they're at. And so we kind of figured out on an average cost, it probably cost about $4,000 a month of just having patients or having inmates supervised with the medical staff and the CO requirements that correctional officers that have to kind of follow them around and make sure that they're following all their safety protocols. So if you give them an injection, they don't have to go every day or twice a day to go get their medications. They can give it and they walk away. There's no diversion of this, right? We see it go into the body. The other is kind of long-term health cost. If you do some kind of rough calculations, one of the other things I've done kind of in my career, I worked for a health insurance plan for a little bit. And so we would get all this data about patients and their other medical, comorbid medical conditions that had opioid use or substance use disorders. And if, you're thinking we're capturing patients, we're getting them the treatment that they need with, extended release type medication. So they get back into their primary care docs, they start to take care of their other health needs. If anyone knows anything about Hep C, if it goes untreated, 20, 30 years later, you develop late stage Hep C, which may potentially lead to a transplant. So by catching these patients early, keeping them engaged in treatment, we could probably say with just 11 patients that are getting treatment, somewhere north of, $500,000, $600,000 just by using some of these treatment plans. So again, a different way to think about the care for us that, may not be directly on the medical lines, but, in charge of policies and managing clinics. And, we have to look at spreadsheets at the end of the day. Like this is an interesting conversation to have about what, why we should be doing this. Lab wise, pretty straightforward. The recommendation is that if someone is going to continue to be at 300 milligram dose, that you should get monthly liver function test. Unfortunately, I don't do that all the time because sometimes that's kind of hard. Sometimes the patients just don't want to get labs that day, and that's okay. But definitely keep on kind of a regular monitoring schedule. We do the liver function test because the medication is metabolized through the liver. Just like, again, it's regular buprenorphine. That's all. It just comes in a different kind of delivery mechanism that's there. So, and a little bit of concern about hepatic impairment and should you discontinue the medication. I mean, if possible, this is where you get the GI doctors, the hepatologists, those kind of folks involved to say like, hey, what do you think? Like, how risky is that? I think all of us, we're here today where, we're involved, we're advocating for our patients, but, would you rather have a little bit of liver impairment, or would you rather have somebody leave tomorrow and overdose and die on fentanyl or heroin or whatever? And I'll tolerate a little bit of liver function impairment. This is kind of cool and interesting. So there is another long-acting formulation that just got approved last month. Got held up for a couple of years, COVID, courts, FDA approval, all that kind of stuff. It is supposed to start with distribution in September. It's a different, still a long-acting idea, but the cool part about this, I think, is that it comes in weekly as well as monthly. And it comes in different formulations. So, not everybody has to get 300 or 100. We can dose this a little bit different depending on, where they're at in their treatment plan, where they're at in their recovery. I mean, my kind of thoughts of how I might use this is to help somebody that is doing well and wants to kind of start tapering down on their medication. And so we have some different options. The other cool part, this doesn't have to be refrigerated, which we'll talk about in a second of, why that is something you have to think about, and this can be injected into different sites. So right now, again, it's just with Sublocade, it's just subcutaneous around the abdomen, but this one you can do it in the buttocks and the thigh and the abdomen, upper arm. It gives you some different options, and probably because it's this liquid gel that's there. Again, research kind of supports this, the long-acting formulations, sustained engagement and treatment, the typical kind of research requirements that we look at substance use disorder research, abstinence rates, all that kind of stuff. I mean, definitely outperforms placebo, no questions asked. Like this is a good treatment option for patients. Patient selection wise, the patient that's still taking their buprenorphine 3 times a day, maybe not the best one to start out with, because they're going to have just a cognitive frame shift of, I'm going from taking a medicine 3 times a day to now I don't have to take anything because I got an injection. But I do think it's helpful, pharmacy refill issues, patients that can't get to the pharmacy, the pharmacist, they don't have the 8 milligram strips, they want the 12. A good idea of transitioning from an inpatient setting to an outpatient setting, to incarceration to an outpatient setting, because you're going to have the medication there. And because the long-acting effect, patients that are in withdrawal or to prevent withdrawal, so you don't really have the withdrawal. If someone, us in the treatment world, someone's on 24 milligrams of Suboxone, you stop it, there's going to be some withdrawal that's there. Not really that big of an issue with the Sublocade. Again, teens, awesome idea for teens, right? Because teens are a little bit unreliable, especially in the substance treatment world. Pregnant women, there haven't been any studies. I personally have probably given it to 15 pregnant women. They love it. They think it's great because they don't have to worry about the pharmacy. They have a new baby at home. All that kind of stuff is important to them. For some patients that have nausea with the oral formulations and you switch to the injectable, it doesn't seem like it makes that much of a difference. That was one kind of thought early on when it came out. So, I think it probably has something to do with the chemotactic issues, not necessarily a GI absorption, first pass effect. I will take like 3 or 4 more minutes because I want to make sure that, Sarah has enough time to talk kind of about her kind of unique experience, but just kind of some patient related things that, things that you would think about. So, cytochrome P450, how the medication is metabolized. Had a patient, started her on the injectable. She's coming back at like every 18, 19 days and full on opioid withdrawal. I mean, COWS scores, everything, physically looking, somatic symptoms, the whole thing. And I was like, you know what, I don't do this much, but let's test it. You can do an enzyme genetic test to see. And lo and behold, she was a rapid metabolizer. And so we just decided, hey, the oral form is just not going to be beneficial for you. It's just wearing off too soon. And we were bridging it with oral medications between appointment, and it was just too much. I've only seen 2 people ever actually allergic to the matrix, and they were actually 2 siblings. So again, assuming it was a kind of a family related, would get these really big, nasty looking skin ulcerations that would be 3-4 inches wide, and actually have them see an allergist and say, yeah, this is definitely a matrix. It's not a technique issue. The other is a technique issue. I'm going to skip to the next one. So on the left side, it says good. On the right side, it says bad. So this is a subcutaneous injection. Unfortunately, with this patient, we had a new nurse in the office who thought she was supposed to be giving it subdermal, not subcutaneous. And so this patient got this somewhat unpleasant looking necrotic skin reaction that we did have to have plastic surgery get involved. So the adverse event for any kind of injection is 1 in 1,000. In our office here, we've probably given about 2,500 injections over the last couple of years, and I've only had 2 patients. So that number seems pretty correct about kind of any adverse event. Some people ask, like, what happens? Like, how often does this happen with the injection? And again, it's relatively really rare. So this is a Reams certified program. So if you're your treatment setting and how you're going to deliver this to the patients, you do have to think a little bit through this. The specialty pharmacies are great as far as being able to deliver it. I think the pharmacy world understands the urgency of when someone needs this injection. We can't wait a week or 2 for a prior auth. New York is great with the lack of or no prior auth issues. So we are really fortunate here to be able to have that. I know not every location in every state has that. But some people's, particularly prescribers have said, I want to be able to deliver this, but the facility I'm working in can't do this. They can't get Reams certified. So they'll send it to a local urgent care, or they'll partner up with another primary care practice or another mental health practice that's maybe already doing injectable medications, things like endocrinologists who are doing, Prolia injections, and say, hey, they're already doing this. So can I just ship this there? And then when we need it, we can get it. It does have to be refrigerated. And so, you can't have the delivery showing up on Saturday morning when no one's in the office. Again, maybe something that the newer Brexati will kind of get past all of that, but it does come in a big cooler box. It's funny, you get 15 or 20 of them in a day. You do have to think about where you're going to put these and refrigerator space and some of those other things, but easy things to work through. And I'm happy to help you. If you have any questions about how to do it, how to start, I'd love to be able to help you. Just some real world applications. Not everybody is the most adherent and compliant with our treatment plans. If you do miss, say you just don't get to the injection, like in our area, it snows sometimes, so people can't get here. You can go about 2 weeks before you kind of have to restart the whole process again, the 200, 300s, and then the 100 milligram. And then let's say somebody wants to go back to the oral form. The first question is why? Like, what's the purpose of you doing that anyway? And then the second is you got to wait about 26 days from that last injection to be able to go next. Again, it self tapers. So if you get, 6, 7, 8, 10 injections and somebody says, hey, I'm ready to get off, definitely I say, hey, you don't need to do anything else. Just stop it. It's going to be in your body for a couple more months. I have pushed it out to about 8 weeks. After about 8 weeks, you actually can start to do iatrogenic induced withdrawal symptoms. So, 5, 6, 7 weeks at the most. But again, the recommendation is for 4 weeks. And then even decreasing dose, you can do 50 milligram, half milliliter injections, things like that. And, there's some models out there that have used this to come to patients say, I don't want to be on this long term, but I don't want to do the taper with the Suboxone or methadone or whatever. Just give me an injection and let me go. And say, all right, well, okay, sure, we'll do it. And give a 300 or a 100 milligram injection. Again, you saw the chart earlier on. It shows you those blood concentrations, and they leave and they're doing relatively okay. And unfortunately, some of them come back because of the relapsing nature of this disease, but some of them you don't see again, and hopefully they're in a better place. So that's my piece. I know we gave you a lot of information. Well, I think we're saving questions and stuff for the end, so I'll give it back to Narelle and Sarah.
Thanks very much, Nick. Yeah, I see some questions in the chat there, and I'm loving that some people are responding there too. But we'll move over to Sarah next, and if we have time, we'll get to questions. And if there's any lingering questions, we'll circle back after the event. So I'll hand over to Dr. Spencer. We can see it. You might just want to.
Are you able to see my slides? Okay.
Yeah, you just might want to put it into the mode.
Okay, hold on. Let me try again to share.
We can see. You might just want to go enter full screen or presentation mode if that works.
Are you seeing it now?
No.
Stand by, coming through.
Are you able to see it now?
Not yet.
It's not coming through?
No.
It's not coming through?
No.
Okay, and bad internet. Share. Are you able to hear me?
You're cutting out a little bit. Do you need us to maybe share your slides?
Okay. Yeah. Yes. Can you hear me right now?
Yes.
Okay.
Good. Yep. Thank you.
Okay. I have really bad internet where I'm at right now. And so are you able to hear me at least?
Yes, we can hear you. You know what I'll do is I will share your slides. So I'm going to stay on audio only, and then just give us audible cues to advance the slides, and we can do it that way.
Okay, that sounds great. Let me know if I'm cutting out and you're not able to hear me.
No problem. Here it comes.
Okay, so I work in rural Alaska. I work for Tribal Health and been providing addiction treatment there for quite a while. I'm going to talk a little bit about some different ways, a little bit out of the box, maybe off-label ways to use extended release buprenorphine, and specifically in high-risk patient populations. So I'm going to talk a little bit about patients who use methamphetamines with opioids, which is most of our patients in rural Alaska, and about how we can kind of modify the way we offer this medication to reduce the barriers and help engage and keep more of these patients in treatment. Next slide. Next slide. So we're going to talk about the epidemiology of how common comorbid stimulant and opioid use disorders are and their associated overdose risks, talk a little bit more about the pharmacology of this medication and how we can reduce barriers to this medication and how that might help to keep people in treatment. Next slide. So in Alaska, 2021, we had the largest increase nationwide in overdose deaths and up by 75%. And methamphetamine and fentanyl specifically each went up by 150%. And in Native Alaskans, it was 3 times higher than in white Alaskans. Next slide. And fentanyl has been ubiquitous in our drug supply for a long time in the opioid supply, but now we do have patients that, they actively use fentanyl as their drug of choice, mainly in the form of these blue M30 press pills. There's also fentanyl contamination of stimulants like methamphetamine, and there are other fake counterfeit pills like counterfeit benzodiazepines that are actually made out of fentanyl. So even if someone has their opioid use disorder controlled, they may inadvertently, unknowingly be exposed to fentanyl through the use of other drugs. Next slide. And the co-use of methamphetamine with opioids has more than quadrupled since 2015, and the incidence is significantly higher on the West Coast. Next slide. In our clinic, what we have seen since 2016, initially we were seeing, the minority of patients using these 2 drugs together, only about 1 in 4. A couple of years ago, when we looked at our numbers, it was 3/4 of all patients using methamphetamines with opioids. And this last year, the vast majority of my patients, I would say it's more than 80, approaching 90% of my patients report co-use on admission now. Next. And methamphetamine related deaths have also quadrupled in the last 5 years. And we know that the use of methamphetamines with fentanyl increases overdose risk in comparison to using either drug by itself. And, the really powerful and rapid onset of the respiratory depression of fentanyl combines synergistically in a negative way with the negative cardiovascular effects of the stimulants, which together increases the overdose risk. Next. And so since it's so dangerous, it's important to ask about, why do people use these 2 drugs together? So they did interviews and published a paper on this last year, asking people who use them, why? So the main 3 reasons: first was to prolong the effects of the fentanyl. Next, to counteract the negative effects of opioids. I hear this from my patients a lot, kind of balance the effects out, help them to keep them awake and keep them from nodding out. And last, just to get the, the positive effects from the amphetamines, like the increase their energy. I need it to help me get up in the morning and get to work and that sort of thing. So we can see since the fentanyl contamination has become so heavy, we can see why people are increasingly adding stimulants to the mix to improve their experience. Next. And so my job is the most important part of my job is to keep my patients alive. And we know that the #1 evidence-based way to reduce mortality in opioid use disorder is through medications for opioid use disorder. And those can reduce death rates by up to 80% if we can keep people on meds in the long term. But we know that when people stop taking their medication, their overdose risk increases dramatically. It can go up 10-fold higher that first month that they stop their medication. So it's really critically important that we retain people on medication in order to reduce their mortality. Next. And a number of studies have shown that unfortunately this high-risk group who use methamphetamines with opioids, they tend to not retain in treatment as well. They tend to drop out of treatment about twice the rate as patients who use only opioids by themselves. But what we really also have seen is that it's not just the patients dropping out, it's patients don't have as much access to care when they're using multiple substances. So they might be refused admission to programs, they may be involuntarily discharged discharged from programs because of their ongoing polysubstance use. They may be involuntarily discharged because they're just, they're having trouble making it to their appointments because of their chaotic life circumstances, surrounding their substance use disorder. So the current system of care really is not designed to be able to provide these folks with really severe substance use who are actively using drugs to help to keep them in treatment and provide adequate care for them. Next. So low threshold care is a strategy that we can use where we focus on the patient's goal, and from a harm reduction lens, try to reduce as many of the barriers as possible to make treatment medications as easy to access as possible. Next slide. So low threshold care programs can have many different things that they offer. The number one thing, though, is that we're not ever going to discharge patients for ongoing drug use. We're really going to focus their care plan on their particular goals, as much flexibility as possible. So in our clinic, we try to offer same-day telemed appointments for people who want to get into treatment, and walk-in appointments for people who want to get their follow-up injections. Next slide. And offering as much really holistic care all under one roof in one place as possible. So people do come into an in-person visit, a lot of these people have been so traumatized by the medical system, they don't have a primary care. They have so many other untreated medical conditions. So we're treating their Hep C, even if they're still actively using drugs. We're making sure they have contraception if they want it. We're trying to help them treat their depression and anxiety and their chronic pain and their insomnia and all these other triggers that are affecting their quality of life and affecting their drug use. Also distributing harm reduction supplies from our clinic to people who are still using, making sure that they have safe injection equipment, smoking supplies, naloxone, and testing strips. Next. So some advantages to utilizing extended release buprenorphine in rural areas. First of all, we don't have to worry about diversion. Diversion is a huge cause of barrier to access to care, because there's a lot of stigma around the fear of diversion of sublingual buprenorphine, especially in kind of the remote tribal areas. And so they just won't offer treatment at all in those villages. And so this at least offers, an option for a medication that you don't have to worry about monitoring it. You don't have to have the extra case management work of doing things like medication counts. You don't have to do urine drug screen for compliance issues. So a lot less burden, on that for monitoring the medication itself. Medication interruption is always a risk in remote areas. So if a patient, if they can't get to the clinic due to transportation barriers or weather, if they can't get to the pharmacy to fill their prescription, if the mail order medications don't come in the mail because of weather holds, all of these things, when someone's on sublingual buprenorphine, they run out of their medication, they lead to, acute severe withdrawal, and that can really trigger return to use and increase overdose risk. However, with the extended release buprenorphine, because it wears off so slowly, you're not going to have that abrupt onset of withdrawal symptoms. So you have a lot more flexibility to kind of reschedule appointments and allow people that flexibility of when they can come in and get their shot. And it really is currently it's the highest dose of buprenorphine once people stabilize that is currently available, and the longest lasting. So for people who might lose access to care, it's really nice because their medication will wear off very slowly, and they'll be protected for a longer period of time. Next. So we do, to make treatment more accessible, most of our patients are traveling for 30 plus miles away to come see us. Many of them don't have a car of their own. Many of them don't have a license. They don't have money for gas. So it really reduces no-show rates and allows for more flexibility to do that initial intake via telemedicine. So, and we often are able to fit that in on the same day or the next day. Then we can really talk about patients about their treatment options and their goals, and give them their instructions, over the phone. And a lot of this is over the phone, like over half of the time, either on the patient center, even our clinic clinic end. We have crappy internet, and then video doesn't work. So phone is great for us. We offer lots of different options. If people have had trouble in the past with precipitated withdrawal, we offer them options like a low dose overlapping start or a high dose start, so they feel more comfortable in being able to start their medication at home. But we also talk with people, some people, they have had such traumatic experiences with precipitated withdrawal in the past with buprenorphine that they absolutely refuse to take sublingual buprenorphine. And so we do have some people that come in and they haven't been able to start taking their sublingual buprenorphine. And we tell them, if you can't, it's okay. Come in anyway, and we'll talk about the options of maybe giving you your shot without having taken any buprenorphine prior. So this would be for people who have experience with buprenorphine in the past. They know they've liked it in the past, but have trouble starting it, and do have a current opioid tolerance, so that the side effects, they won't experience too much side effects from the high dose buprenorphine when they get the shot. We always provide supportive medications like clonidine and Zofran and naloxone, and it takes us a little under a week for the shot to ship to our clinic. So it works out pretty well doing telemedicine the week before and then having the patient follow up the next week to get their shot. Next slide. So high dose buprenorphine, the dose of buprenorphine that you get when you stay on the 300 milligram shot is like 5 to 6 nanograms per milliliter. And when they've tested that in the clinical setting, when they looked, at people who are only on not have any buprenorphine on board, as they gave them increasingly high doses of fentanyl, up to 800 mics, so almost 1 gram of fentanyl in a single push, those people basically became apneic. But when people had serum drug levels of 5 nanograms per milliliter of buprenorphine, like you would get with high dose extended release buprenorphine, they didn't have any respiratory suppression, with the fentanyl. And so it's very protective against fentanyl-induced respiratory depression. What they did see, though, is that as that level dropped down to 2 nanograms per milliliter and below 2 nanograms per milliliter is where you start to lose the efficacy of that blockade of fentanyl. So especially when people are at risk for continued fentanyl exposure or continued use, having a really high level of buprenorphine can be more protective of them for overdose. Next. And the real extended effect of this medication is really one of my favorite things about it. So the key to this is you do have to get patients stabilized. You have to get them, 4 or 5 shots in. But if they are able to stabilize, if they lose access to care, so like in our area, we have people that go out fishing, salmon fishing in Bristol Bay for 3 months. People who are at risk for incarceration, and Alaska is kind of hit or miss whether you're going to get any MOUD when you're incarcerated. So if we can get them stabilized on buprenorphine on the 100 milligram, after they stop, they'll maintain over 2 nanograms per milliliter for about 2 months. And at the 300, they will maintain at therapeutic levels for up to 5 months after their last shot. So really an extended period of protection after interruption of medication. Next slide. So ways to reduce access to this medication, improve access and reduce barriers to this medication. So first of all, we always give it to patients regardless of their active drug or alcohol use. And we make sure that patients know that, like if you show up at our clinic and you want your shot, you are going to be able to get it. It does not matter what drugs you've been using lately. You can always feel safe talking with us about that if you're interested in stopping the use of other drugs. We don't require drug testing before giving the buprenorphine. We don't need to for medication compliance issues. And again, some people don't want to do drug testing. They may have legal reasons they don't want it on their record, so it's fine. They're usually very honest with us. They tell us usually exactly what they've been using. They just don't want to provide a urine sample, so that's fine. We don't have to worry about that. A lot of flexibility with schedule. We'll give people, their shots late. We don't necessarily require a reinduction, with sublingual buprenorphine, allowing people to walk in for their injections, pretty much at any time that we're able to squeeze them in. And increasingly for opioid tolerant patients, we are doing single day initiation where either we'll have someone, take buprenorphine for just a day or two, or even if they haven't taken any at all, still giving them their injections. And the only, folks who have really struggled a lot with precipitated withdrawal in the past, the most of them do really, really well with that. Most of them don't have precipitated withdrawal. It's only, in our experience, it's been like about 1 in 10 patients that will have precipitated withdrawal, but that's always been their struggle. But if you have precipitated withdrawal by taking sublingual buprenorphine, it's really hard to keep making yourself take a medication that just made you violently ill versus, if I'm doing it to you and you can't take it out, yes, it stinks, but you can get over that hump. And after a couple of days, you're going to feel better. And we make sure we explain to people how to treat precipitated withdrawal, that you take high-dose buprenorphine, you take 16 milligrams right away, and then take another 8 milligrams, up to 32 or 40 milligrams in addition, that first day or so when the precipitated withdrawal is bad, along with adjunctive medications. We also do the flexible dosing where we get part of a syringe if needed. We always offer sublingual supplementation for the first 2 months, because we know that those levels at the end of month 1 for sure drop down below that 2 nanogram per milliliter, and they're lower than they would be if someone was taking 24 milligrams of bup. So they're not necessarily protective for people who have ongoing drug use. So we say, hey, it's normal to feel that it's wearing off, because it is wearing off at the end of the first month, and we do want them to take additional sublingual bup at the end of the first couple months if they need to help protect them more. And we do offer it in pregnancy in the 2nd and 3rd trimester. Try to avoid it in the 1st trimester. There's some studies in rats that show that this component in the gel could possibly be teratogenic. So we do have a pregnancy consent form we have people sign for those high-risk people who sublingual just doesn't work for, and they really need to be on the XR bup to succeed. Next slide. Patients tend to really has very high patient satisfaction rating, like over 80%. They love that it's very easy to access. They love that they can just wake up feeling normal every day without the hassle of taking daily medication. And they love that if they miss their shot or they're late for their shot, that they don't experience acute withdrawal. Next slide. So we looked at our data in our clinic. We looked at our patients, this patient population who used methamphetamines with opioids. It was 55 patients. And we looked at the cumulative amount of buprenorphine treatment that they were able to accumulate over their course of treatment. And we compared patients who only took sublingual buprenorphine to patients who got at least one extended release buprenorphine injection. Next slide. And what we found is that the patients who had at least one XR bup injection actually had 13 more cumulative weeks of buprenorphine therapy, which is about 3 months. And when you also factor into that the pharmacokinetics, in that they may have actually had therapeutic drug levels for a much longer period of time than that calculated length of therapy suggests. Next slide. I'm done here, last slide. And more likely to have longer period of therapy. Next. So in general, this is a high-risk population. We need to reduce barriers to this medication as much as possible, and everyone should be working on that. So sorry, I went a little over. We have time hopefully for a question or two.
Well, thank you very much, both of the presenters. There's a lot of rich information in this. I see there's a number of questions. I think some of them might have actually been answered through both of your presentations. Unfortunately, we don't have time for Q&A, but we will be capturing the questions and be checking in with our presenters, and we'll be able to respond offline, because I see there's some questions around
I'll write some
coverage and technique and with benzodiazepine. So we'll circle back, but thank you so much. This has been wonderful. I think it's really exciting to see how these new formulations may really make a huge difference for a lot of folks. So I'll hand back over to Paul. Thanks so much.